Hello, so this is the obesity paradox, when thinner means sicker and heavier means healthier. Part 1, a paradox for the ages. Chapter 2, the ultimate scapegoat, the conventional wisdom about obesity as a modern scourge. Ask any well-read person on the street what obesity can do to one's health, and you'll hear a litany of challenges that exact a tremendous price. Honestly, I don't feel like going through all of them, and I'm going to add a video instead of reading them.
Welcome to UW Health at the American Center and the University of Wisconsin Metabolic and Bariatric Surgery Program. I'm Dr. Michael Guerin. I'm one of 4 bariatric surgeons here at the University of Wisconsin. I'm pleased to welcome you to our world-class, state-of-the-art facility here in Madison, Wisconsin. We're an MBSA QIP certified center for bariatric surgery. I'd like to take a couple of minutes of your time to discuss the disease obesity. After treating obesity for the better part of my 25-year surgical career, I've come to understand the impact that obesity can have not only on your health, but also your quality of life. I've come to understand the frustration that comes with repeated attempts at weight loss through diets, exercise, and sometimes even medication. I know that many of you have experienced the dreaded yo-yo phenomenon with your own weight loss attempts. Obesity is not a lifestyle choice. Obesity is a disease. In fact, obesity has become one of, if not the leading cause of preventable death in the United States. By some accounts, more people die each year from obesity than do from smoking cigarettes. Some of you may remain relatively healthy despite dealing with the disease of obesity. Most of you are probably already dealing with some sort of affliction related to your weight. It is clear that your future holds the possibility of developing some serious medical problems unless you are able to deal with your weight effectively. Most people understand that obesity is the major risk factor for developing the life-shortening disease of diabetes. Many of you already carry this diagnosis and know the many complications that can come with it, as well as how it can degrade your quality of life. Many of you are already using CPAP machines at night due to the diagnosis of obstructive sleep apnea. Did you know that sleep apnea is a weight-related disease and that it is in fact life-threatening? Those of you from Wisconsin will remember the great packer Reggie White. Did you know that he died from complications of obstructive sleep apnea? While there are many diseases such as diabetes and sleep apnea that are widely known to be related to obesity, there are many others. Did you know that over 13 types of cancer are related to the diagnosis of obesity? Did you know that so-called fatty liver disease has become the #1 reason that people require liver transplants in this country? Medical conditions such as breathing problems, hypertension, heart disease, hypercholesterolemia, venous stasis disease, degenerative joint disease, female infertility, polycystic ovary syndrome, and heartburn or GERD. Yes, each of these is directly linked to the diagnosis of obesity, and there are many others. I suspect many of you think about how obesity has affected your quality of life. From painful joints, to feeling winded with activity, to unfair social situations, obesity is far more than a clinical diagnosis. Obesity can be a cruel and life-altering condition that robs people of their deserved joy and happiness of everyday life. Our team at the UW Metabolic and Bariatric Surgery Clinic is dedicated to helping you along the journey away from obesity. From the surgeons, nurses, health psychologists, exercise physiologists, registered dietitians, medical assistants, and our professional colleagues throughout UW Health. On behalf of them, I give you my word that we'll do everything we can to help you along the journey to better health. I invite you to view the following videos to become introduced to our team and to learn more about the journey to better health through bariatric surgery at UW Health.
Recent evidence indicates that obesity is associated with more diseases than smoking, alcoholism, and poverty. Excuse me. Many argue that should we fail to stop the obesity epidemic, we will soon lose serious ground on extending life expectancy. We may see our lives getting shorter, but I would temper such an ominous statement by challenging the current definition of obesity when it comes to blaming all manner of mortality on it.
I'm delighted to be here today and to discuss about the article that will be appearing in the upcoming issue of the Mayo Clinic Proceedings. So in this very broad, comprehensive review of the literature entitled Obesity and Heart Failure, Focus on the Obesity Paradox, that I wrote together with Dr. Chip Lavie from the John Ochsner Heart and Vascular Institute and Dr. Ross Arena, which is a professor of physical therapy at the University of Illinois in Chicago. We wanted to emphasize the role of and describe more in details the role of obesity in heart failure. There is in fact a controversial role of obesity in heart failure. On the one hand, obesity seems to be a risk factor, an independent risk factor for the development of heart failure. On the other hand, when patients has obesity and heart failure at the same time concomitantly, obesity seems to exert some protective effects. And more specifically, we looked at the importance of the role of body composition in the development the development of heart failure, and how body composition compartments, more specifically fat mass, fat-free mass, and lean mass, might actually play a protective role once heart failure is diagnosed. In a brief summary, what we found is that the lean mass seems to be really important to play a major role in both the development but also in the potential protective role of obesity in heart failure. More specifically, there are some hemodynamic and structural changes of the heart of our patients. They might be due to obesity and specifically to increased amount of lean mass. But also some negative effects of some other negative effects of adipose tissue that is able to produce a certain amount of pro-inflammatory cytokines, also named adipokines, with direct cardiodepressant properties. In reality, the World Health Organization defines obesity as an excess body fat that impairs health. I think it's really important to highlight the importance of assessing body composition to determine if there is an excess of body fat. Once heart failure is actually diagnosed, lean mass might exert protective effects. And how is that even possible? We think that lean mass is a major determinant of cardiorespiratory fitness in patients with heart failure, and cardiorespiratory fitness is an important predictor of mortality in this population. And the higher amount of lean mass is been associated with better cardiorespiratory fitness. So the idea is that the higher is the amount of lean mass, the better will be their cardiorespiratory fitness. What we believe and we advocate for is for an assessment of body composition in our patients, not just to determine the amount of fat mass the patient have to determine whether they're obese or not, but to determine whether they also have a reduced amount of lean mass. And if there is a reduced amount of lean mass, these patients will be classified as sarcopenic, whether if they have a reduced amount of lean mass in association with an excess body fat. At that point, we will be talking about a condition called sarcopenic obesity, which has been associated with worse outcomes in a number of chronic disease and recently also in heart failure. We then discuss the role of a diet in the development and progression of heart failure. We think that if you eat a healthier diet with a lower amount of sugar and saturated fat, they might be having some beneficial effects by reducing the amount of systemic low-grade inflammation. Our body, when we measure our body weight, we only have a rough estimate of the quality of our weight. To really determine whether somebody is obese or is not obese, we really need to measure body composition. If you have an athlete, especially if, like for instance, rugby players, their BMI might be 35, 40. We had sometimes we had an athletes in the past that had BMI higher than 45. They would classify them as a very obese, severely obese. In reality, you go to measure the body composition, and their amount of lean mass or muscle mass is so high that you would never define them as obese subjects. That's why the body composition assessment it becomes extremely important. On the other hand, you might have a subject with a BMI of 23, which might be considered a normal body weight for in relation to their height, but some patients might not be very fit, and so they might have a lot of fat mass compared to the lean mass, and in that case, they would be still considered not a very good body composition status. Well, the takeaway message, I think, is that the treatment of heart failure It cannot just be one. And we think that the assessment of body composition for a better nutritional status certification is essential, as well as some non-pharmacologic therapies such as exercise training and more specifically resistance training, to trying to increase the lean mass and the muscular mass in our patients, as well as a low saturated fat and low sugar diet. And to do so, I think that the multidisciplinary approach plays a major role, in which physicians, nutritionists, exercise physiologists, and pharmacists, they have to work together. Because one of them, it's not enough.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.
Obesity and the kitchen sink. The law of compound returns governs obesity relationship with virtually every health condition for which fatness is often blamed. This law is often used in economic circles to describe how wealth grows. A small snowball rolling down a hill will gather weight, which increases its speed, which keeps increasing its size. We can apply the same law to the topic of health conditions linked to fat. Although one health condition can make for a small snowball, such as high blood sugar, that initial condition can quickly trigger others, which add to the snowball and generate more momentum as the ball gets going down the hill. As more risk factors accumulate, the snowball has become a very large, unyielding boulder. Obesity. Notice as you listen to these ailments, which came first, the obesity or another related illness. The old chicken and egg scenario pervades when it comes to all things obesity related. What is metabolic syndrome? You often hear about this condition in terms of obesity-related illnesses. It's often referenced when obesity is connected to things like high blood lipids, insulin resistance, and high blood pressure. Metabolic syndrome is simply the name for a group of risk factors that raises your risk for heart disease and other health problems, such as diabetes and stroke. In addition to high levels of blood fat, additional risk factors include low HDL, high triglycerides, and high fasting blood sugar. In general, a person who has metabolic syndrome is 2 to 10 times as likely to develop a heart disease and 5 times as likely to develop diabetes. Smoking, inactivity, and plain old genetics are also strong risk factors, but they aren't classically categorized under metabolic syndrome. Numerous overweight people carry no other signs of metabolic syndrome other than their weight. High blood pressure. Blood pressure is the force of blood pushing against the artery walls as your heart pumps blood. If this pressure rises above normal and stays high over time, it can damage the body in many ways. Your chance of having high blood pressure are markedly greater if you're overweight. But you can be thin and have high blood pressure. The condition isn't always about obesity. Because so many people have high blood pressure without knowing it, many of them of normal weight, it's often called the silent killer. Coronary artery disease. As your body mass index rises, so does your risk of coronary heart disease. A condition infamous for the waxy, fat-like substance called plaque that builds up inside the coronary arteries. These arteries supply oxygen-rich blood to your heart, but plaque can narrow or block them, reducing blood flow. The most influential risk factor isn't obesity, however, it's age. Over 83% of people who die from coronary heart disease are over the age of 65. Smoking also contributes to this disease. Stroke. Plaque buildup in your arteries doesn't just threaten your heart, it can also cause a stroke. If the area of plaque ruptures, causing a blood clot to form that can be carried to the brain, where it can block the flow of blood and oxygen, the risk of having a stroke rises as BMI rises and increases. But the top 3 risk factors are in fact high blood pressure, diabetes, and smoking. These factors apply to many normal weight people as well as overweight people. Not everyone who suffers from a stroke is overweight. New research is showing that one strong predictor of risk for stroke is low HDL cholesterol. This explains why young, seemingly healthy people can suffer from a stroke. Abnormal blood fats. If you're overweight, you're much more likely than normal weight people to have abnormal levels of blood fats, such as high levels of triglycerides and LDL cholesterol, and low levels of HDL. Abnormal levels of these blood fats are risk factors for heart disease. Atrial fibrillation. Obesity is a known risk factor for atrial fibrillation, which is an irregular and often rapid heart rate that commonly causes poor blood flow to the body. During an episode of atrial fibrillation, the heart's 2 upper chambers beat out of sync with the 2 lower chambers. Aside from obesity, other often stronger risk factors include advanced age, high blood pressure, excessive alcohol intake, another heart condition, and of course, genetics. These risk factors can exist regardless of obesity. Cancer. These days, it seems like virtually anything questionable in our environment, diet, and lifestyle can be traced to an increased risk of cancer. After all, cancer remains one of our most formidable challenges in medicine, the ultimate boogeyman in health, which begs to be fully understood. Today, we can associate an increased risk of several types of cancer in different organs with obesity: esophagus, pancreas, colon and rectum, endometrium, kidney, thyroid, gallbladder, and breast cancer after menopause. The exact mechanism by which obesity can fuel these cancers are still largely unknown and complex. Obesity probably just adds another ingredient to the mix that tips the scale in favor of cancer's growth. The older you are, the higher your risk for cancer of any kind, despite weight. Once we reach middle age, our body's ability to combat cancerous growth weakens naturally. Osteoporosis. Osteoporosis is a common joint problem of the knees, hips, and lower back. The more weight you carry, the harder it is for your joints to work properly. Hence, even small changes in weight can significantly affect the joint pain experienced by an individual. Genetics are likely to play as well, since there are plenty of thin people walking around with arthritis. Again, that is due to inflammation that's triggered by other mechanisms in the body unrelated to weight. Sleep apnea. Sleep apnea is a condition in which a person stops breathing momentarily and frequently during the night or during sleep. Or the breaths are so shallow that at some point the individual has to gasp for air, causing them to move out of deep sleep. Some studies suggest that sleep apnea causes hypertension, and it's also strongly correlated with the entire basket of cardio-related conditions such as congestive heart failure, stroke, coronary artery disease, heart attack, and irregular heartbeat. It's also related to headaches, memory problems, mood swings, feelings of depression, and even impotence through several indirect pathways. People with sleep apnea are not always obese, but many of them are, and they also bear other cardiovascular risk factors that could be related to fatness or not. Having these other risk factors that could increase a person's chance of sudden cardiac death, so the sleep apnea may be the tipping point. Asthma. The link between obesity and asthma may not seem clear, but researchers looking for the reason behind the rise in asthma cases alongside obesity have surmised that the low-grade inflammation that occurs throughout the body with obesity may be a factor. In 2010, a study of a nearly 4,500 men and women from the National Health and Nutrition Examination Survey, about a third of which were overweight, and another third were obese. 41% had some type of allergy, while 8% had asthma. 12% of the obese individuals had asthma, compared to 6% of the normal weight individuals. And the likelihood of asthma rose as body mass index increased and waist circumference expanded. The researchers pointed out that such findings don't rule out the possibility that insulin is a link between obesity and asthma, or that insulin resistance comes long before obesity sets in. Kidney disease. Obesity and kidney disease go hand in hand for one big reason. The kidneys filter the blood to produce urine. So if there's anything going on in your body that negatively affects how the kidneys perform, they can easily become abused. Indirectly, obesity increases the major kidney disease risk factors, such as type 2 diabetes and high blood pressure. Directly, any of these conditions would force the kidneys to work harder, filtering above their normal level. Indeed, obesity can ultimately result from kidney disease, not the other way around. And there are lots of thin people walking around today with all the risk factors for kidney disease, except for one, extra fatness. Obesity is the kitchen sink. Although obesity is nowadays blamed for everything but the kitchen sink, in truth, it is the kitchen sink. It's a center of gravity of sorts, from which we can draw an epic assortment of associations, however remote. But because of this, in many ways, obesity is also the ultimate scapegoat. And we often blame obesity as the prime suspect, even when it's a mere coincidence of other problems, consequence of other problems going on in the body. We can find relationships with obesity and its negative effects on virtually every system and organ in the body. Most all of obesity's adverse associations can be traced back to the functioning of the heart, where they have a direct or indirect relationship with the cardiovascular system. One fact is clear: the presence of high body fat changes our chemistry, down to the ways in which our heart beat and pump blood throughout the body. At the center of all these chemical changes is a topic we must address prior to leaping into the details of the obesity paradox itself. That topic is inflammation. Inflammation's dark side. We've known for some time now that the cornerstone of most chronic conditions is inflammation. All of the conditions outlined in this video share a direct relationship with inflammation, much more so than they do with obesity. Inflammation explains the tender redness of a cut or insect bite. Although it is often cast under a dark light, inflammation is necessary for survival, serving as an indication that the body is trying to defend itself against something it believes to be potentially harmful. Without inflammation, we couldn't be able to combat foreign invaders like bacteria, viruses, and toxins. But if you have too much of it, you can have too much of it. Problems arise when inflammatory process turns on and stays on, disrupting your immune system and leading to chronic illness and disease. The strong relationship between inflammation and obesity, and in fact fat cells, is subtler than the link we can visualize and likely feel when we have a skin abrasion or achy back. But fat inflammation is responsible for a lot of the conditions we attribute to obesity. It's as much a key player in diabetes as it is in hypertension, even though both of these conditions come with separate systems and are categorized differently. Work is also underway to understand the role of viruses and gut bacteria in contributing to body weight and disease. Our intestines harbor billions of bacterial colonies that collaborate with our digestive and even immune functions. Some of these colonies have been implicated in the obesity epidemic, while others have protective benefits against weight gain and metabolic disorder.